Good morning, everyone. It's 8 o'clock. Welcome back to another week of Cardi-OH Clinic, your patient with diabetes at risk for heart disease, series of case discussions. We're already on to week 7, if you can believe it. And I'll just go ahead and hand it over to Dr. Rao so he can do introductions for the day.
Thank you, Jesse, and welcome back, everyone, to another week. We are more than halfway through this particular series. So this morning, we have two very, very interesting cases, as always, from Dr. Shalab. Dr. Sharma, unfortunately, is not able to be with us this morning, so I will be presenting her case. She did submit it some time ago, and we're going to start off with a great presentation by Dr. Beverly. I've asked Dr. Wright to be our commentator specifically on both of these cases because the issue of blood pressure and diabetes is such a critical one. So obviously patients whose blood pressure is uncontrolled, who have diabetes, are at very, very high risk for cardiovascular disease. So with that intro, Liz, do you want to take it away?
Thank you, Dr. Rao. Hi, everyone. So this morning, I'm going to present a brief didactic on advanced care models. The objectives for this morning are to describe the structure and function of teams caring for patients with type 2 diabetes, to describe the benefits and format of group visits for type 2 diabetes, and to define shared decision-making in its application. Next slide. So advanced care models. Quite simply, advanced care models deliver comprehensive person-centered care for people with advancing chronic conditions like type 2 diabetes and cardiovascular disease. So the things that we've been discussing throughout this case series for Project ECHO. And advanced care planning is the process that enables individuals to make plans about their future healthcare. What makes advanced care models unique? Well, some of the things that make them unique are the use of alternative value-based payments. And some of the other key features include care coordination across provider settings, shared decision-making with the patient, family members, and providers, access to clinical support, and then depending on how advanced the chronic illness is and if they're approaching palliative care, access to clinical support might actually be 24/7. And one of the other key features is concurrent curative and palliative treatment. So we know that providers have a lot on their plate and they're expected to do one too many things, but one of the things that they are expected to do is to conduct advanced care planning with the patient. So taking into consideration, plans about their future healthcare, what are their values and preferences for care. And so the idea behind an advanced care model is to help extend primary and specialty care providers into the home through the help of an interdisciplinary team. So this helps the primary and specialty care providers with advanced care planning. It helps the patient and the family members as well. So overall, the goal is asking the patient to document what their preferences for care are, their values for care, commuting that information then to the providers, and then the providers can then oversee that preferred medical care plan. And the ultimate aims are, if you can then have this preferred medical care plan, you're enhancing the quality of care because it's the care that the patient and the family prefer to have. And it also lowers costs because they're only receiving the care that they specified that they want. And so it's that preferred care plan. Next slide. So we all know the diabetes care team, and there's so many members, and this is not an exhaustive list of the care team. This is just a list of some of the care members that we have discussed, and we have a lot of these care team members here participating in this ECHO series. We have the primary care provider, we have endocrinologists, diabetologists, we have the eye specialists, the foot specialists, dentists, nurses, certified diabetes educators. We have nurse educators, registered dietitians, exercise physiologists, lots of physical therapists and occupational therapists, pharmacists. And it's really important to integrate mental health care providers, considering people with diabetes are at increased risk for a lot of psychosocial issues, in consideration diabetes, depression and anxiety, and diabetes distress. So thinking about these things when you're coming up with the advanced care planning, as well as and creating this advanced care model, you're putting together the team. Now, of course, the advanced care model, you have to consider the resources at your practice or your healthcare system and who's available to be on that team. And then for the individual patient, if that individual patient has a chronic progressive condition like type 2 and they're experiencing specific complications or a lot of comorbid conditions, you might then be working with palliative care or hospice care expertise. Next slide. And one of the things we're talking about in terms of having that interdisciplinary team is looking at shared medical appointments. So there has been a lot of research on shared medical appointments with people with type 2 diabetes. And so I'm going to share a little bit of that information with you. So shared medical appointments is actually quite well known in the state of Ohio because there's been a lot of work out of the Cleveland area on shared medical appointments through the VA as well as the Cleveland Clinic. So these are planned visits that are coordinated for a group of people. And I'm going to refer to this in terms of type 2 diabetes, and it's using an interdisciplinary team. So the goal behind this, it increases access to diabetes education. And this is because you're using a team. And it also increases education in the primary care setting because this group of individuals will be seeing a primary care provider or a specialist provider, but you'll have access to education. It also integrates peer support, which reinforces self-care. And there's a lot of research that documents the benefit of peer support when it comes to reinforcing self-care behaviors. So there have been 2 meta-analyses that have been published about shared medical appointments, specifically for people with diabetes. And these meta-analyses have shown, both of them, that there have been improvements in A1C by 0.6%. And generally, when you're looking at an improvement in A1C to make a clinically meaningful difference, you want to see about 0.5%. And so what these meta-analyses showed that this 0.6% translated to a decrease in 10.5% of deaths due to diabetes, a 7% decrease in MIs, and a 19% decrease in microvascular complications. So the shared medical appointments have been very effective for people with diabetes, and it's another way to integrate the interdisciplinary care team for advanced care planning. Next slide. Again, just to reinforce what are the goals behind the shared medical appointments, it's building engagement. It's to inspire behavior change. We've had several didactics about how difficult it is to integrate lifestyle behaviors. And when you see your peers who may also be struggling, you can also be a source of motivation. And it's also an opportunity to talk about those shared experiences. So the shared medical appointment, there's no standard format, but there have been some components that have been documented as what other shared medical visits have looked like across centers. So they have a brief individualized visit to assess a patient's condition, and that's with the primary provider. And then there tends to be a group discussion that's facilitated by the provider. And again, this model will depend on whatever organization or clinic is using the shared medical appointment. And in terms of who's composed of the interdisciplinary team, you have your provider, and that provider can be a primary care provider, it can be a specialist. You can have a medical assistant with you, a documenter or someone to take the notes and document the visits, and then having a diabetes educator, a dietitian, or a behavioralist, or having the educator as well as someone who specializes in behavioral health. Next slide. And then, of course, one of the things that we talked about as being crucial to advanced care planning is that shared decision-making. And what is shared decision-making? It's joint consideration of clinical factors and individual preferences to arrive at a decision based on mutual agreement. And again, decision-making is critical for advanced care planning because it's asking the patient and the family members what is it they want for their future health care, and then working with the clinician to figure out based on a mutual agreement of what is the best care plan. There's actually been a lot of shared decision-making interventions in type 2 diabetes, and some of the findings from these interventions have shown the following. It's shown an increase in diabetes knowledge, patient satisfaction, improved communication between the patient and the provider, congruence with values and decisions, which falls into accordance of the advanced care planning. There's been less patient indecision. There's been improved risk perception and improved decision quality. Next slide. So thank you very much. And I would also just like to point out that we have several wonderful providers here who've done shared decision-making. I'll pass it back to Dr. Rao.
Thank you, Dr. Beverly. Any questions for Liz about shared decision-making or advanced care models in general? And does anyone have any experience to share, as Liz was suggesting? I appreciate the definition of shared decision-making, Liz. It seems that, at least from the research angle, lots of different things seem to qualify for shared decision-making. And there is this mistaken belief that simply as a physician, sharing my thinking around the decision that I have made is shared decision-making. That's not it. So people turn their computer screen and say, this is why I'm putting you on this medication. It really is a more detailed discussion of benefits and risks and coming to some sort of consensus together. And I think that that's a critical element that people need to understand. But appreciate your presentation. We can move on.
Sure, thanks everyone. Just a couple of reminders and a couple of other opportunities. So you should actually have 2 surveys coming into your inbox. They're probably not quite there yet. So you'll have your usual post-clinic survey, and then you'll also have what we're calling the contact demographic form. This is just some basic info. It helps us for internal evaluation purposes, but we also usually put together a contact sheet for each cohort. So at the end of the series, I can share that so you're able to still contact one another and use each other as a resource, as well as have access to some of our content experts from over the 12 weeks. And then next, please. Just to let you know, we do have another sort of educational opportunity. We will be hosting a cardio webinar on December 1st. It's over the lunch hour, noon to 1. You'll see here it's management of type 2 diabetes in the adolescent and young adult. There's a registration link there, but you can also find the info on our website, cardio.org. And then lastly, another opportunity for you, which I have emailed this group about, but we do have registration now open for our spring Cardio-ECHO series, and that will be focused on weight management, so titled Weight Management and Behavior Change, Cases and Discussions. I know Dr. Rao spoke to this, but it will kind of follow the same format as this, just different topic, and that'll be running January 27th through April 14th, and in this same Thursday morning time slot. So just wanted to let you know about those opportunities. Look for those surveys in your inbox, and yeah, we're a little bit early, but I think if there's nothing else, we'll see everyone next week, and thanks very much.
Thank you, Jesse. Thanks, everyone. See you next week.